Good evening, everyone. This is Lieutenant Richards, and in this short presentation, I'm going to discuss thyroid disease and its implications with regard to anesthesia. Most of the information in this presentation will come directly from our assigned readings for this segment, which were Chapter 34 in Morgan and McHale, and Chapters 44 and 46 in our Barish text. I've also pulled some good information from our Stolting's coexisting text. I expect this to be a fairly quick and straightforward review, highlighting the most important points to remember when you are tasked with taking care of a patient with thyroid disease. When I initially started to prepare this presentation, I somewhat doubted the need for an entire review on one hormone-producing gland. I almost felt like anesthesia for thyroid disorders could be covered in a few slides in a general endocrine review. However, as I started getting into the reading and reviewing the physiology, I actually began to worry about being able to succinctly review this topic in under a couple of hours. So as this came together, I tried to focus on the bottom line, which is what are the implications of thyroid disease to my anesthetic plan? So we'll start with a very basic physiology review of thyroid hormone function, production, storage, and release. We'll then go ahead and talk about hyper and hypothyroid specific diagnoses, clinical manifestations, treatments, and anesthetic implications. We will close the presentation with a quick introduction of an interesting topic for discussion. As we will discuss in detail, thyroid disease can have major effects on some of the main body systems that we try to control on a daily basis. It is important for the nurse anesthetist to fully understand or at least anticipate these changes when asked to provide an anesthetic for both thyroid-specific and non-thyroid surgeries. The American Thyroid Association estimates that 12% of the U.S. population will eventually develop a thyroid condition during their lifetime. This is a relatively large percentage when you think about the array of diseases, disorders, and dysfunctions we see within our patient population. Depending on your clinical location and rotation schedule, we've likely provided well over 200 anesthetics at this point in our training. Statistically speaking, it's likely that 24 of those anesthetics involved patients with some type of thyroid dysfunction at some point in their life. That's 24 chances to provide a better anesthetic by understanding the implications of the patient's condition. In essence, our patients expect more than cookie-cutter anesthesia and deserve a personalized and thoughtful anesthetic experience. The goal of this presentation is not to reteach thyroid physiology and pathophysiology, but rather to serve as a general review to help study for exams, as well as to generate a thorough discussion surrounding this topic among appropriate group members. I will not be providing a comprehensive physiology lecture, and will refer you to the previous class notes and readings for in-depth details. However, in order to bring everyone to the same page, let's briefly review the main physiological points. Remember that thyroid hormone plays a role in nearly every metabolic process and affects multiple body systems, including the cardiovascular system, gastrointestinal system, and the central nervous systems. Most importantly, thyroid hormone is responsible for ATP regulation in cellular metabolic processes. Such processes include lipid and carbohydrate metabolism, as well as tissue growth and maturation through protein synthesis. Through various complex mechanisms, thyroid hormone causes increased cardiac contractility, decreased systemic vascular resistance, and increased intravascular volume. Thyroid hormone also plays a primary role in thermal regulation. The general result of these processes is increased oxygen consumption and CO2 production. Let's look at the production, storage, and release of thyroid hormone. Iodine is absorbed through the GI tract, transported to the thyroid gland as iodide ion, and converted back into iodine once inside. The thyroid gland serves as a site of conjugation for iodine and thyroglobulin. This process, referred to as organification, results in the creation of inactive forms of thyroid hormone, monoiodotyrosine, MIT, and diiodotyrosine, DIT. The majority of MIT and DIT is then recycled back into the thyroid gland for storage, while just 25% is converted into active triiodothyronine, T3, and thyroxine, T4, via a process called coupling. As you recall, T4 and T3 are the active forms of thyroid hormone and are released into the plasma at a 10-to-1 ratio respectively. Remember that T3, although released in much smaller quantities, is 3 to 4 times as active as T4. In addition, T3, unlike T4, is a more active player in the periphery with regards to protein synthesis. This is a picture directly out of our Stolting's Coexisting Disease text on page 386. If you need a more visual review of the thyroid hormone production, this seems to break it down into its most important parts in a fairly straightforward fashion. The stimulation of production and release of thyroid hormone is controlled through a negative feedback mechanism. The hypothalamus releases thyrotropic releasing factor and thyrotropin releasing hormone in response to decreased thyroid hormone levels. Thyroid stimulating hormone is then released from the anterior pituitary to signal thyroid hormone synthesis and release. Here's another visual representation of the process we've just reviewed. This one comes out of our physiology textbook by Costanzo. I'd now like to address both hyperthyroidism and hypothyroidism individually, placing emphasis on their clinical manifestations and anesthetic implications. Typically, hyperthyroidism can be suspected in the presence of increased serum T3 and T4 with a subsequent decrease in thyroid stimulating hormone. Clinical manifestations would be consistent with a hypermetabolic state. The patient will occasionally present with a fine tremor, exophthalmos, or goiter, and cardiac manifestations including atrial fibrillation, sinus tachycardia, and congestive heart failure. Propylthiouracil and methimazole are part of the primary treatment regimen and function by inhibiting thyroid hormone synthesis. Both have relatively short half-lives, emphasizing the importance of achieving appropriate drug levels and euthyroid status prior to elective procedures. Patients may also be taking beta blockers to decrease the conversion of T4 to T3 in the periphery, which must be considered while formulating an anesthetic plan. This just gives you a picture of how someone with hyperthyroid dysfunction may present. Symptoms that have a very direct effect on our anesthetic plans are circled in red. Perhaps the most important preoperative consideration for patients with thyroid dysfunction is ensuring a euthyroid state prior to any elective procedure. This includes obtaining a thyroid panel that demonstrates normal serum levels of T3 and T4, as well as ensuring the absence of any resting tachycardia or other overt signs of hypermetabolism. Part of ensuring a euthyroid state, as discussed earlier in this presentation, is continuing the patient's antithyroid medications, specifically because of their relatively short half-life, and any beta antagonists, if applicable, on the morning of surgery. Intraoperative factors that must be considered include avoidance of agents that would unnecessarily stimulate the sympathetic system. In addition, the anesthetist must closely monitor fluid volume status, cardiovascular function, and body temperature, as patients will be most likely to experience more fluctuations in these systems throughout the procedure. Poorly managed patients with hyperthyroidism may experience a slightly larger degree of hypotension on induction, secondary to chronic hypovolemia. Neuromuscular blocking drugs should be administered cautiously, secondary to an increased rate of myopathies and myasthenia gravis in patients with thyrotoxicosis. Thyroid storm is the greatest risk to the hyperthyroid patient undergoing surgery at 6 to 24 hours after surgery. Thyroid storm manifests with tachycardia, high fever, altered level of consciousness, and hypotension, and requires urgent and extensive medical treatment. Management of thyroid storm is generally described in our readings in Morgan and McHale and will be discussed in detail in the discussion board to follow this presentation. In patients who have undergone a thyroidectomy, the provider should understand the risks and manifestations of recurrent laryngeal nerve damage, hematoma formation, and acute hypocalcemia from inadvertent parathyroid gland removal. Hypothyroidism, on the other hand, can be suspected in the presence of a decreased serum T3 and T4 and increased or decreased levels of thyroid stimulating hormone, depending on whether the dysfunction is primary or secondary. Clinical manifestations include weight gain, cold intolerance, lethargy, constipation, muscle fatigue, hypoactive reflexes, and depression. The patient may present with mottled and cool extremities secondary to vasoconstriction and will most likely have a decreased heart rate, contractility, stroke volume, and cardiac output. Primary treatment for hypothyroidism is thyroid hormone replacement. This is another simple visual representation of hypothyroid disorders and its associated symptoms and manifestations. Again, items circled in red stand to directly affect the efforts and interventions of the anesthesia provider. Thyroid replacement medications, unlike thyroid hormone inhibitors, have a relatively longer half-life. As such, while it is appropriate to continue these medications prior to scheduled surgery, it is not necessarily unsafe to proceed in cases where they have been held. In the intraoperative period, ketamine and etomidate may be helpful induction agents to mitigate the more dramatic hypotensive response to anesthetic agents. In some cases, adrenal insufficiency may also be present secondary to prolonged hypotension. These patients are also more susceptible to hypoglycemia, anemia, hyponatremia, and hypothermia. Lastly, patients with hypothyroidism may present with facial edema and a larger than average tongue. Because of the increased incidence of hypothermia and respiratory depression, these patients may experience prolonged emergence or even require temporary mechanical ventilation postoperatively. In the last few minutes of this discussion, I would like to introduce a topic for discussion that seems to lack clear and substantial evidence for best practice in the literature. As nurse anesthetists, we will be providing anesthesia for patients with thyroid disease during non-thyroid surgeries, but also in the setting of thyroid-specific surgeries. As some of you have seen firsthand, goiter and an enlarged thyroid gland can present challenges for airway establishment after induction of anesthesia. In addition to these difficult airway considerations, providers must plan for postoperative pain control. In a bad airway situation, it may be prudent to utilize local anesthesia in the form of a specific nerve block or request that the surgeon provide a more generalized field block. In their study, Egan et al. Investigated the efficacy of a superficial cervical plexus block versus a simple field block in patients undergoing thyroid or parathyroid surgery. While the power of their study may be somewhat lacking, with only 29 patients enrolled, they did find a difference in pain management in favor of the superficial cervical plexus block. The study was well organized and carried out and may serve as a good resource to you in the future. With that in mind, and with the rate of military humanitarian missions rising, I would encourage you to discuss with your colleagues the different methods used for these potentially challenging patients. I would like to thank you all for your time in reviewing this presentation. It's been my pleasure to review thyroid dysfunction and anesthetic implications with you all. Please take a look at my references for further study and don't hesitate to contact me with any questions. Thanks again.